All right, welcome everybody. We're really excited to talk about this session. This, of course, is a plenary panel, the morning session. Today's is evolution of the telehealth workforce, opportunities and challenges. I am one of your moderators, Brian Arkwright. We also have...
And I'm Rob McKenna, co-moderator from HRSA. Hi, see everyone again.
Yep. I'm gonna kind of kick things off, and then we'll have the panelists introduce themselves. A couple reminders, some kind of logistics type things. We ask that we keep the bios short for those up here and the virtual panelists, and in true matrix fashion, check the website for the bios. We're not giving long bios. And also, please use the poll. There's a poll question. I'm going to read the poll question. And then Rob and I will kind of go back and forth reading the questions and dialoguing with the group. So the poll question is just really to kind of help us get started of what best describes your organization for those in person and, of course, attending virtually as well. So the poll question: what best describes your organization? Are you a technology vendor, a physician or clinical provider company, an academic medical center or school of medicine, hospital or health system, insurance company, pharmaceutical company, federal, state, or local government department or agency, consulting or advisory group, venture capital or private equity group, and non-healthcare business or other? Also threw other in there if you don't fit any of those. Here we go. Live answers. This is great. Oh, look at the changing things. Cool. So we've got a lot of hospital health system.
Most people, almost more than half.
Yeah.
So this tells us that none of the vendors next door have made it over.
Yeah, they're still at their booth. Yeah.
Still at the booth.
It's a good one. Well, awesome. Well, we want to kind of just see the audience a little bit. Thank you for that. And I'm going to turn it over to Rob to kick us off with the first question.
Sure, and I'm not sure we introduced our speakers, right, our subject matter experts.
So I'll get started. I'm Kathy Schwarting, and just so you know, it takes a while for me to get going. So if you ask a question and a little delayed reaction, y'all forgive me. I'm from South Carolina, and I run Medicare Connections. We are a nonprofit telehealth network, and we also lead our state's broadband consortium.
Awesome. And we'll jump to Sally first.
Sure. Good morning. It's really wonderful to be here with all of you virtually. My name is Sally Na, and I'm Associate General Counsel for Inova Health System in Northern Virginia. We're a 5-hospital health system with lots of different outpatient ambulatory facilities as well. And again, it's great to be here.
Awesome. And Dr. Bobby Kumar, next.
Hi, everyone. Thank you so much for the opportunity. My name is Bobby Kumar. I'm a family physician, and I'm Director of Clinical Transformation for Inflect Health, which is the innovation and investment hub of Vituity. Vituity is a national physician partnership. We've been around for about 45 years and across 25 different states. I also serve as Medical Director for Healthful, which is one of Vituity's new startups, where we offer healthcare, patient care navigation, and other patient-facing solutions. Nice to meet you all.
Awesome. And Rob Sprang?
Hey, Rob Sprang. I am the director of UK Telecare, which is the telehealth initiative at the University of Kentucky.
Awesome.
And thank you all for being with us. And so, yes, there are two Robs. That's Rob S. and I'm Rob M. for clarification. And please do take a moment to read bios if you'd like to know more about our subject matter experts. They are worth reading. They're terrific, just like I'm sure all of yours. So thanks everybody for being here with us today. As Brian said, we have some prepared discussion questions, but we really do want this to be a discussion that looks like what you want it to look like. So do feel free to step up to the mic if you're here in the room to ask your own questions. If you're remote, please feel free to start posting questions in Event Mobi. Vote them up if you want to, and we'll go back and forth between what we've prepared and what you'd like to discuss in the moment, okay? So our first prepared question, Rob S., I'll start by aiming this at you, and then anyone else who wants to chime in can. So from one telehealth office department supporting an organization or health system to everyone in an organizational health system being part of that office or initiative now, have you experienced telehealth office permeation? Is it a good thing?
Yeah, thanks, Rob. And before I get started, I just want to ask the group by show of hands, how many of you were at the Matrix conference in Williamsburg in 2019?
Ooh. It looks to
Okay.
be about 2/3.
So imagine, guys, and I was at the meeting as well, but imagine I had told you at that meeting that within the next 12 or 13 months, every clinician in your healthcare system would be demanding to use telehealth. First of all, you'd have left me at the bar and walked away. But imagine what happened over that next 12 months after the last Matrix meeting. And kind of comparable to that, this whole concept that we had of telehealth office permeation. From the early 1990s, telehealth offices were typically a standalone organization within the medical center. And back in those days, technology was expensive, it was unreliable, broadband was almost non-existent, but at least it was incredibly expensive at the same time. And if you could get beyond all those barriers, you could be pretty assured that when your providers submitted claim forms, insurance companies would reject them. So telehealth was often not in the strategic plan. The telehealth office needed to be skilled in fundraising, grant writing, legal and regulatory advocacy, technical skills relating to clinical staff. They needed to know how to do outreach and develop affiliations across their catchment area. And they need to be creative. I mean, we had to develop applications that supported clinical, educational, research work. But this meant the telehealth office was often isolated, and that team was primarily responsible for driving telehealth adoption. And of course, in the spring of 2020, everything changed. COVID emerged. Patients quit coming to clinic. Elective procedures were canceled. And, if you paid attention within your organization, the term elective procedures took on a really interesting title for me. Looking around, I noticed that cancer treatments were often considered an elective procedure. If you had cancer, I don't think you would have thought that cancer was procedure was an elective procedure, but that was the case. We didn't know what we were about to face, and we have the luxury of looking back now to see what happened. And at the same time, the legal and regulatory hindrances were relaxed, so telehealth did become more practical, and it became the first option in nearly every healthcare system. And every healthcare provider quickly migrated their outpatient practices. Telehealth proved its value on the inpatient arena, both in the emergency department as well as inpatient rooms, not only to limit provider exposure, but also to limit PPE usage. And telehealth was elevated to the highest importance. And suddenly everyone in the organization took responsibility to drive telehealth strategy forward. You couldn't mention the healthcare strategy without mentioning telehealth. And the telehealth office continues to have a critical role. But it's so interesting to see the responsibility for telehealth is now distributed across the entire medical center. And it's exciting to see what telehealth can achieve. It's what we all had hoped for. And, as they often say, be careful what you ask for, because we got it now.
Any other panel members like that?
So I will add to that. In South Carolina, I've been with Paramedic Care Connections now for 12 years. And so when the pandemic hit, it was like we were moved forward maybe 10 years into the future. That's how much telehealth grew for us in that short period of time. And for my small office of 10 folks, I think within the first week of knowing that we had a pandemic in the area, I think we issued like 800 user accounts to providers in South Carolina. So we had spent years trying to get providers to even consider the concept of telehealth. And then all of a sudden, within 1 week, everybody wanted to do it. And guess what? You didn't even have to do all the training. I mean, all the hours we had spent training them in the past and giving them the protocols and making sure that we had infused it correctly, that just went by the wayside. All of a sudden, they were doing it, boom. And it was amazing, actually.
Yeah. I second.
I apologize.
No, go ahead, Bobby.
In our organization, we saw something very similar. Speaking to how, I feel like healthcare innovation sometimes can be a little delayed when it comes to adoption. And so we had built our telehealth platform probably 5 years before COVID even started. And we were partnering with payers and health plans to provide telemedicine service, and adoption even from patients we didn't see it as much as we would like. And then COVID happened and everybody started scrambling for how are we going to reach these patients? And we were already equipped to do so. What we started to see though is that a lot of the efforts for telehealth to reach patients and their family members was really locally driven. So we were seeing health systems, local clinics wanting to adopt this technology to reach these patients and rather it be centralized with our tele-urgent care panel of 30 doctors doing this from California to all their states that they're licensed in. We had our local urgent cares, our primary care clinics, our hospital systems, the emergency departments going locally, sending care teams out into the field with devices to provide telehealth in the field, which was very unique. Not something that we had ever anticipated 5 years ago to be seeing care teams doing that now.
Yeah, and I'll jump in as well. I will say I am a byproduct of this permeation. As Rob mentioned, I did not raise my hand about being at the conference in 2019 because, to be honest, telemedicine was not on my radar, other than potentially as an audit point for were we collecting informed consent for the telemedicine we were providing. But because of COVID, I certainly got a crash course, as did all of our organization. And as many have mentioned, I think what was so fascinating and amazing for me to see is how much of this became clinically driven by our physicians and our frontline staff, and how quickly the teams assembled to meet daily, weekly. In the beginning, it was all hands on deck, and everybody was providing from their areas of expertise how to make this work. And so what would have taken, as we've all heard, 5 to 10 years, because we would have scheduled meetings out, monthly or quarterly or every, whatever, we were doing it daily, and we were getting real-time feedback as to what was working with patients and what was not working with patients. And we were able to deploy this in months rather than years.
It's such great comments to hear from the panel. And we have such a great panel in terms of, we have kind of an administrator type who's got a statewide view. We have a clinician who's both leading it and doing it. We have Rob, who's kind of been in the telehealth office for many, many years, leading it. And then Sally from the legal side. And I think that's a good, representation of telehealth, that it takes all of those key stakeholders, and great point by Sally that all those stakeholders were meeting so frequently, and it involved each and every one of them to some extent to really, harness and optimize and really make it doable, make it actually achievable. Any other comments on the telehealth office permeation? I could talk about this all day. But I don't. Awesome. All
All
right.
right. We do have a question that's been submitted
All
online
right.
and has been upvoted. So
Awesome.
let's go
Ooh, and
there.
upvoted.
So when you consider telehealth as a service line, do you favor an integrated delivery model within existing bricks and mortar or a dedicated service line, much like the transition to hospital services? And if you favor integrated, how do you address the loss of providers' ancillary income?
Well, that's a good one.
So I can start first in what I feel is the best. As a family physician, urgent care physician, one of the shifts that I feel like we have seen in healthcare is that it used to be you had a patient that went to multiple different locations, and now we're shifting into where it is the patient is able to essentially the care is coming to the patient. So you have the patient is actually in multiple different locations. They can be anywhere. They could be at home. They can be in their office. They could be in their driveway, and they're receiving care from multiple different care team members. And so I value an integrated care team model where it may be, and I feel like for really true comprehensive care, you're having the support system of whether it's a brick and mortar or if it is from the hospital facility, if it is a transitional care management program from the emergency department, from the acute care facility going back into the community or to the medical home. I feel like there is the added benefit of having that integration. Now, that's not to say that I don't think there's value in telehealth that is not housed in a brick and mortar. I just think for the specific use case that we identified the value that a care team brings. In regards to how we account for the loss of ancillary revenue, I think that's bigger than what this conference can even speak to. We need to have major reform in how healthcare is currently being reimbursed. We launched a program in Southern California where we were delivering care for select patients, observation level care in their home. And at that time, there was parity in payment. We were able to get Medicare to actually pay for the services that were being delivered for 24-hour observation level care in the home. And outcomes were better. Patients recovered better. We had a better patient and clinician satisfaction. Overall, we saw such a tremendous value in doing so, but we were only able to do so because it was reimbursed. And how we account for those losses, unfortunately, it trickles back down onto the health systems, onto the patients. And so we can't, that is essentially not sustainable.
So I would agree with Bobby on the integrated model. And I will say along the reimbursement end, South Carolina is one of only 7 states that has no parity policy in place. And we've been fighting this for years. And our biggest opponent every time we go to the legislature are our payers, not necessarily Medicaid, but our private payers. And so we've had a big discussion in South Carolina with telehealth and eliminating that originating site requirement. The payers now do not want to pay at 100% of what the providers would get for a face-to-face. And in their mind, it doesn't take as much overhead, right, to provide that care if it's via telehealth. Well, in a rural state like South Carolina, and we're predominantly rural, you go back to the healthcare provider, and that's not the story, because now what's happening is you've got patients that you're doing telehealth with that are not maybe technology savvy. Maybe they're older and they don't remember their password. They don't remember how to dial in. So the provider's office staff is still spending that same amount of time with the patient, but due to hurdles or barriers on the patient side, and the providers, the healthcare providers are saying, well, it's still taking my staff just as much time, but the payers are saying, well, that's not my expense. So we're going back and forth and having that big debate in our state over how to compensate for that time period.
Yeah, I'll just comment real quickly on kind of the integrated hybrid model. You sometimes hear it described as, I think that where you're giving that practice the opportunity, both patients and the providers, the opportunity to say, hey, here's the things that work well for telehealth video. Here's the things that work well for telehealth audio. And then here's the things that work best for you to come in. And giving, it's actually an opportunity to give some opportunity of selection to the patients and the providers of, well, I'd rather come in for that, so I'll come in. But also really matching, visit types, reasons for the visit, diagnosis, really getting down to some serious detail, and that also can kind of give some choice to the patients and the providers.
Yeah, I'd like to touch on something that Dr. Kumar said. Completely agree with the idea of integrated care. But I also think we have to begin to look at as we refer to it often, as the unintended competitive consequences of telehealth. We do a lot of work with our primary care association. Primary care providers are being held accountable for the cost and quality of care. And yet telehealth in its broad base sometimes fractures care. Look, there are insurance companies, and in our case, our Medicaid managed care companies in our own state that are pushing a patient's primary care provider to reduce cost of care and increase quality. That same insurance company has their own direct-to-consumer telehealth platform.
Exactly right.
And they incent the patient to use it, often with no copay. Those visits don't find their way back into the medical record. And so it begins to separate care, and the primary care provider is going to be held accountable, even though they have no control over that. So it's a really interesting aspect of this, that we all are supportive of telehealth, but we're all supportive of telehealth as it wraps around the patient and all moves toward the same goals.
Great point. And that's been around for a little bit, but boy, did it get magnified over the last couple of years. And, it got magnified not just on a lot of these payers and maybe, new entrants to healthcare that you haven't always seen, but they're entering healthcare in different ways. It is definitely disrupting a space. Amazon is a great example of also kind of coming into the space. And we know that they're not just doing Amazon Care in a number of new cities, but they're going to be opening up some clinics as well, some brick and mortar clinics. And so I think there's a list of 20 cities that they're planning to come to over this year, 2022. And it's kind of a phased rollout. But I think that's when health systems are, fortunately, a lot of health systems have started to do telehealth. But the competition is very real. And it's maybe local. It's very different from market to market, but it is something that I think, the leaders in today's health systems organizations that are dealing with telehealth need to be aware of and apply a sense of urgency, maybe in certain areas and aspects to their business, or start a conversation with those payers. How can you partner with them, align to them? We know virtual first is a virtual first health plan is something that nearly every payer is rolling out in 2022. And so how is that gonna, disrupt your own market? Or how can you be a part of it? So it's aligned and maybe benefits your market, and helps you compete with Amazon, but great. Thank you for bringing up the competition. That's something that has been fascinating to watch, especially with all the kind of private equity and venture capital money coming into telehealth as well.
As for the loss of ancillary funds, I just want to quickly mention, I couldn't sit here as a HRSA representative. I wonder I hope folks have heard of the Provider Relief Fund and participated in the Provider Relief Fund. Would you please raise your hands if you know about the Provider Relief Fund? Okay, some of you. So the American Rescue Plan provided tens of billions of dollars that were administered by HRSA to providers and provider agencies, essentially to help them keep the doors open due to the loss of income because of COVID. And I think that's one of the things that actually helped some of the providers transition to more telehealth services, because they were having their income supplemented by the Provider Relief Fund.
Great point. Yeah, great point, Rob. And that might be a good segue to appropriateness of care and clinical scope of practice. I know this is something that came up a lot when we were kind of preparing for the panel. And Sally, I'll direct this one at you, and then would welcome the other panel members to join the question. So again, appropriateness of care and clinical scope of practice for telehealth. Variation exists with individual providers for comfort and confidence of the telehealth encounter, and by specialty based on demonstrated research and best practices in their specialties, mental health, telestroke, etc. What's appropriate for a telehealth visit, and how has your organization dealt with telehealth clinical scope of practice?
Yeah, no, thank you. So as we've been talking about COVID for many systems, telemedicine became a present necessity. It was no longer something that we could wait for in the future. This was a way to keep our patients and our team members safe now, and we had to pivot to it very, very quickly. So this really did push telehealth outside of our traditional realms. It increased dramatically widespread ambulatory use, but it also greatly expanded inpatient use. And I was so happy to see so many fellow hospital and health system colleagues who are in attendance today. So I had actually thought I would start with expansion and scope of practice on the inpatient side, because we don't often talk about that, at least from what I've seen. And honestly, that has been really fascinating to me, because traditionally, as we all know, hospital care has been routinely provided pre-COVID via telehealth, but in certain select services, telestroke, telepsych, EICU monitoring, et cetera. And most of our hospital care was really done in person. So our medical staff bylaws really easily address that staff category of being a telemedicine staff member. But what we really started to see with COVID and the pandemic was more of our providers who were already credentialed, not in our telemedicine staff category, but already credentialed as active members who would have typically come on site. They now wanted to use telehealth in order to do the things that they would have routinely otherwise done in person. And so that raises a lot of questions for us. And, the Joint Commission actually came out and very clearly addressed that, because there were so many questions around. So then, does that require additional credentialing? Does that require additional privileging? And the Joint Commission was very clear in saying, no, you don't need additional credentialing for that. However, and I think this is what was really important for our health system, the Joint Commission did still speak to governance and scope of practice. They made it very clear that the medical staff must determine which services are appropriate for delivery through a telehealth link. These practitioners must also be trained in how to use that technology and to ensure the protection of patient privacy. So you don't need additional credentialing and privileging, but you do have to think about what is appropriate in your care setting where you normally would have done those services in person, and now you're going to let people do it via telehealth link. So that really did call for us for increased engagement from our medical staff leadership perspective to determine what is appropriate. And I thought, rather than lay out what we had decided, because I think every facility is different. I think there's so many different considerations that can go into what is appropriate in terms of scope. I wanted to lay out a few of the considerations that we made or we thought about to frame this question, because I think it applied not only at the time, but will also apply as COVID starts to wane and we start to really figure out, are these services that we've been providing now via telehealth still appropriate? And so obviously, what clinical care can be safely delivered through this mechanism? You're not performing procedures via telehealth. So what are we doing? Is it consults? Is it rounding? Is it what is safely appropriate to be managed this way? And how are you going to then document what those standards are for your organization? Because is it that you're going to let every provider just decide on their own that it's appropriate? Or is it going to be a more centralized decision where your medical staff leadership has some active voice in determining what scope is appropriate? In addition to that, we had to really think through, what if there's a disagreement? You can have a requesting physician who is requesting a consult with a specialist, and that specialist may say, well, I'm not coming in to see your patient, but I'll do a telephone consult, or I'll do some other form of video consult. And what if the provider who's requesting disagrees and says, no, you need to come on site as you would have before? Who gets to break those decisions? Who gets to make that decision ultimately? Because you're going to have different levels of comfort with providers. Some are going to be very comfortable deploying this type of technology and some are not. What are you going to do about patient consent? Are you going to ask patients upon admission if they would agree to telemedicine? Are you going, or do you need to do that every encounter because there's a different level of risk depending on what kind of telehealth what services are going to be provided via telehealth? So we had to really think through consent, because that's one of the issues that are so hard. And how are you going to make sure that all of your providers know that they have to obtain consent? What modes are appropriate? What kind of technology? Are you going to allow personal devices, or are you going to deploy all these devices that are going to be used? How are you then going to document all these decisions that your medical staff or others have made from your hospital administration perspective? And then lastly, the two are more about, is there a threshold, right? So is there a certain surge level or risk level in the community that's going to trigger, yes, now we can do this more widespread throughout the hospital? Are you going to roll that back at a certain point when transmission levels are lower? And what metrics are you going to use to monitor? What are you going to look at? Are you going to track safety incidents? Are you going to track quality or, ultimate outcome quality? Are you going to track patient satisfaction, staff satisfaction? How are you going to make sure that once you've allowed this to happen, it's still meeting the needs of patients and your team members? So those are just some of the things I thought to raise, and I definitely open up to all the panelists for their perspectives as well.
I'll jump in real quick and just, in full disclosure, I am not a lawyer. I am on adjunct faculty with the Wake Forest University School of Law, and I have often found myself working closely with the general counsels and organizations. And everything that Sally just said, those are the details that organizations need to work through and need to answer those questions. And because those are the questions on the providers' minds. And they're not just on the providers' minds, they're on the legal team's, minds. And they're on a lot of not all the administrators' minds, but they're all things that I'm seeing the most variation for in across the system. And as I talk to different hospitals and health systems. And so just really want to point out that those are some great questions to kind of work through if you're in an organization and really wanting to mature and give confidence to your providers. Because I think it's addressing all of those items as well as providing a lot of education. And when you start down the education path, you find that you have to address all those things. And so it can be a nice way to, maybe check off a few boxes. Let's do some education. And oh, by the way, let's answer all of these tough questions as an organization. But welcome any other panel members to add to that.
So I would add to that. I think education is a huge thing on the provider side, but it also trickles down to the patient side. And when telehealth was sort of thrust into everybody's mainstream during the pandemic, they were not requiring that it be HIPAA compliant platforms that you use. And that was a big deal. Everybody was using a different type of platform. And how do you monitor or how do you regulate that? And nobody was advocating for a non-HIPAA compliant platform to be used. But lots of folks, particularly those out in the rural areas, maybe there's some independent rural health clinics, or maybe they're, particularly for us, we don't have very many of the independent rural health clinics that are not part of the system, but there are still a fair number of those that we work with. And the education on their end, they don't have a health system. They don't have legal counsel right there to advise them on the consent forms, on the platform that they're using, on the protocols that they're using. So they were a particular challenge, and the education that needed to be provided to them, like in a split second, because they're already doing telehealth, right? They're not waiting at this point. They couldn't wait to get all of these legal issues. They were thrust into doing it. And so the education was a huge component, and how you roll that out and how do you get it to them as quickly as you can in the midst of what they're already doing.
And one more thing, the tracking component that Sally mentioned, we've seen different reports come out from OIG, DHHS. There's been a lot of challenges at the state Medicaid levels of tracking. Did telehealth visits occur? How many were audio? How many were video? Do we even know? What specialty was it done for? So I think, and those are all the types of, for a long time, I've often said is, almost like a golden rule, and I'd love to hear if anybody agrees or disagrees with this, but you shouldn't be doing telehealth if you can't achieve the same or better quality as your in-person services. And maybe that's hanging out with the general counsels a lot, but but it's a good little simple rule to apply. Like, are we doing this as well? And maybe that there was a lot of gray zone when COVID hit of, well, we just need to do it this way to see patients. Well, now, we can maybe bring the conversation back to maintaining that same level of quality or better, but also tracking it and knowing if we're giving the quality or not. So we'll transition. I'll let Rob read our next question.
Right. We have some activity happening online.
All right.
And please, again, remember, if you'd like to engage, step up to a mic, and if you're here in the room, and we can take your comment or question. Dr. Bobby, I'm going to aim this question first at you, but anybody should certainly feel welcome to respond. So pre-COVID, I espoused the idea that the consumer would drive telehealth expansion. As the pandemic becomes manageable, does anyone feel future growth will again fall back onto consumers, or will providers go back to slowly pushing that rock up the hill? Just thoughts. No one has that crystal ball.
Yeah, no, thanks. Great question. I believe that we are entirely shifting into a consumer-driven health environment. And I think that's sort of where we were headed before COVID, and that we just kind of propelled into that arena now. There is, I think a lot of eyes were opened during COVID about the accessibility to care and how quickly and conveniently people can receive the care that they need. Now, to take it a step further, I think there's also a sense of, I almost want to say urgency, where health systems and clinicians, providers, physicians are wanting to use telehealth more efficiently in their practice and provide a more integrated care model that allows for this type of stuff. And if we were to take away the video component, you may have heard me say this before, as a primary care physician, I was doing audio only telehealth by being on call on the weekends and having parents call me about their sick children and what they should be doing. Or, I'm starting to have a urinary tract infection, and I would be prescribing medications, but I didn't have a platform where I could e-scribe. I was calling the pharmacy myself. I was diagnosing them over the phone, asking for their symptoms, and making a decision plan for them in their treatment. So I guess my point is, now we are in a situation where we can capitalize on the technology that is available to us. We have video. There are remote patient monitoring devices. There are diagnostic devices. Hospital systems have been using remote telemetry for, even when I was a medical student. And that was, having somebody far off monitoring someone's EKG or in the hospital. Now we have EKG devices that can be done at home. There's many virtual primary care practices that actually utilize devices to listen, look into the ears and be able to look into the back of the throat. I've had patients do some very funny maneuvers to use their iPhone to get back into their throat to see if they have exited on their tonsils. Point being, to what Brian, you were saying, that care should be as good as it would be in person. The step further to take is we need to start adopting the technology that allows us to do this. And the consumers will drive that. They want to have that convenience. They want to have that accessibility. They want to know that they can reach the doctor that they have been seeing for ages and at any time from anywhere. And with the adoption of this type of technologies and devices and services that are available, we can actually do that.
I think to Dr. Kumar's point, it's really important that we consider that COVID provided the perfect environment for patient choice and provider choice to have a say-so. But if we hit the end of the public health emergency and all the rules get rolled back, it doesn't matter what patients want to do, because if the providers cannot get paid to see patients for these clinical visits, it's not going to happen. Now that we're kind of tailing off at the end of the public health emergency, it's interesting for us to think about what would have happened had COVID come and yet the payer community had not rolled back all of those restrictions. Would we have seen the same growth in telehealth that we actually did?
Kathy or Sally, any further comment?
No, I'm just excited. We had so much.
We do. We have a comment or question from in the room.
Just wanted to make sure that mic was on. So I just want to challenge this idea a little bit of telehealth should be or could be or would be as good or better than in-person care. Because there are times when simply having access to care is better than no care, right? So I'm in this advocacy space of, I agree, nirvana is it should be as good or better. I'm not even sure it should be better, right? It should be at least as good. And we certainly have, some insurance companies that are doing services, as we mentioned earlier, that aren't necessarily better than going to your primary care physician, but it might be less expensive. It might be more convenient. So there's some other factors. So I just kind of want to throw out the devil's advocate perspective, which is it necessarily important for it to always be as good or better, or can it just be an access to care issue?
I think the answer to that depends on who you're talking to at the moment. I have had to go and present in front of our legislature in South Carolina about the need for telehealth, particularly around mental health and substance abuse use of telehealth, which I think during the pandemic, telehealth proved itself to be a tremendous asset for that community, particularly those that were afraid to come in due to stigma or just the fear of walking into one of those facilities. And I think that the use of it with that part of healthcare was tremendous. So in my arguing with the legislature, it was particularly over substance abuse counseling. We have areas in our state, and I'm sure each of you have areas in your state where you do not have providers, right? So there is no access to care. And my argument to the legislator was, he said, in care, face-to-face is always better than telehealth. And I said, I don't necessarily disagree with that, because telehealth has always been meant to complement in-person care. However, when you are in a community and you need care and you have no provider, is sometimes a telehealth visit better than no care at all? And I would argue that it is, particularly amongst the mental health and substance abuse patients. And it was quite challenging. I was quite intimidated by this, group of legislators arguing with me, but it was very obvious when I asked them what part of the state did they live in. They did not live in a rural area, right? They did not live in an underserved area. So until you've been in that area and you've seen the lack of access, people that have to pay their neighbor $25 to drive them to the doctor's office, that access is a huge issue. And that's the whole reason that I got into telehealth. When I started PCC 12 years ago, I didn't know anything about telehealth, but I had worked for a small hospital, a group of small hospitals, and had done physician recruitment for, 15 years. And two of our small hospitals that were 30 miles apart from each other, they closed within 2 years of each other, right? And I knew how difficult it was to get providers to those communities when we had a support system like a hospital. But without a hospital, really, how are we going to recruit providers and their spouse and their kids to come into these rural communities? And I truly believe with all of my heart that in a lot of our areas, telehealth is the answer because it provides access.
I'm going to piggyback off of that point really quick, just to follow up on whether care should be as good. So I agree on the access point. I'm going to put a plug for primary care. Primary care needs to be as good as it is in person. Primary care costs accounted for, across 31 developed countries, they account for 14% of healthcare spending. And in the US, we spend less than 5%. And we also have the lowest life expectancy of developed nations. So for every dollar that is spent on primary care, the US could be saving $13 in healthcare spending. So I firmly believe that to make an impact on the healthcare system, to make a positive impact on patients, access to care is incredibly important. But the primary care perspective, it needs to be as good. And so we have to adopt the technologies that support managing patients in that holistic, comprehensive manner. And so I'll just stop there.
No, I agree with you, Bobby, very much.
Yeah, and hi, I'm Gemma. I'm from Christiana Care. I love the conversation. Thank you, guys. I have this conversation a lot. I think it's almost like if you take it down to the device level, you have a stethoscope and you have a telestethoscope. Can they function differently? Can one be worse than the other and get the same result? Telehealth's a modality. Audiovisual is a tool. And I think making this comparison, where you're battling against each other, does us all a disservice. It needs to be that this is an option. When we trigger it, I think to Cindy's point is really important. Is it a Band-Aid for the pandemic, or is this the way the world's going? And I think there need to be some decisions because I think consumers are going to drive it. You can't tell them that they can do this and it's equivalent and it's okay in a pandemic. And then because of the dollars and cents of the payers, well, what was good then is no longer good now. So was it ever good then? I think you run into a lot of questions about, the tech and the tools and what you're doing to connect for access versus the politics and the money and who's going to get rich off of it. And the two need to really focus on the patient as the center, and they're not. And we're going to all struggle until they do. That's the frustration in all of this. We're all adopting what we know lets us touch a patient. In this argument that if you do a telehealth visit, it's somehow a substitute and a lesser visit is always interesting to me because going in and seeing somebody in their home sometimes opens a lot of eyes versus them going into the doctor's office and pretending everything's fine. So in some cases, telehealth's better. I can maybe do some things to fix a patient where they are that I couldn't do in the office or in the hospital because I treat them in the hospital and then send them back home to the environment that might be awful and then wonder why they come back and then blame them for coming back because you must not care about your healthcare. So I just think that this becomes way more complicated and a lot more considerations than just, is this in person as good as, the telehealth visit? So sorry, that's my soapbox.
No, these are great points. And I think that's, I raised the question that there is a lot of gray zone. There is a lot of variation. And it does come down to the specialty sometimes. I think we're seeing some amazing things in telebehavioral health. We're seeing some amazing things with those eyes into the home. And so I think that when you encounter those things, that we strive for quality, strive for a quality visit wherever we do, just kind of set those standards and what we can achieve. Next question, I think we still have some time, is leveraging care in multiple settings. with a varied workforce. So great transition, huh? Telehealth was all, and I'm going to aim this question at Kathy, but invite all the panel members to answer. Telehealth was already prevalent prior to COVID in the home, inpatient, outpatient, and ER settings, but COVID required it to be scaled at a massive level in those existing settings and beyond to ICUs and parking garages, drive-through COVID clinics and parking lots, field hospitals and stadiums. How has telehealth stretched the care you give at your organization or what you've seen with the health systems and to new environments, settings, and locations?
I'd like to add to that, if you don't mind, sort of a core of the focus of this topic, this session's topic. What types of new roles are you seeing as being needed as you look into the future?
Yeah.
So pre-pandemic, I would say that our organization primarily focused on the healthcare provider side, right? And then when the pandemic hit, we started getting lots of phone calls from patients. They'd say, people that knew us would say, I have a telehealth visit tomorrow. I don't know what that means. What does that mean for me? How do I do that? Nobody told me, right? And so we talked them through doing that. And what that opened up to us was the patient needs to be educated as well, right? So now we do a healthcare provider side for education, but we also do a patient side for education. And what we found was, in looking at some of our clinics, we had, I think, one of our largest FQHCs in South Carolina. They would start a telehealth visit, and about 50% of those would end up being converted to an audio visit using the phone because of challenges on the patient side. So either the patient didn't have the technology, or the patient didn't know how to use the technology, or they didn't have internet in their home at all. And so what that did for us is we started a digital literacy program last summer. And I will tell you, I've been working in rural healthcare for about 27 years. And this is probably one of the most self-satisfying things that I've ever done, is to teach people. And so what we've done is we started with senior citizens because they were so impacted during COVID. They couldn't get out and see their family, right? My dad, he's 75 and he broke the rules. He wanted to see his grandkids, but if a member of our family was sick, he's stuck at home for 2 months by himself. And I can hear the depression in his voice when I'm talking to him over the phone, right? So teaching seniors was so enlightening. We taught them not only how to use a device and what telehealth meant, we showed them how to do a telehealth visit. We connected them to their provider. We would download an app on their tablet where they could visit their actual provider, not somebody that they didn't know, but their primary care provider, right? We taught them how to go online and research their own health information. We taught them how to do mind-enhancing games, things to keep them active if they were going to be shut up at home by themselves. And they were so eager to learn. You'd be amazed. We had a 95-year-old lady in a wheelchair, and you're thinking 95, right? She was sharp as a tack. I want to say she was probably sharper than me when I got here this morning, and maybe even now. But the age, it's really not relevant sometimes. She was still very healthy. She wanted health care. She wanted to learn how to do a telehealth visit. She tested the little stylus for us. I mean, these individuals were amazing, but to teach them technology at their age and how to access care through video conferencing, which in their lifetime, I'm sure they never thought about, but it was really amazing. And they caught on very easily, and they really enjoyed doing telehealth. I would have to say, probably we had a 95% very high satisfaction rate on the patient side once they actually understood what telehealth was.
That's so awesome.
Yeah, I think to Kathy's point, I suspect many of us heard this, but when patients called and asked, I really don't know what telehealth is. And in our case, when we first launched it, we said, well, that's with Zoom. And the patient would respond, oh, I know Zoom. That's how I go to church. So
That's right.
we found this intersection between people's daily lives and their healthcare services.
No, such a great story. Thanks for sharing that.
You're
Well, we have only 3 minutes left, and we do have somebody in the room who'd like to comment or question.
Testing, yes. Emmanuel Opati here from Johns Hopkins. I think we can all agree that the current workforce was not prepared for telehealth. Only people in this room were prepared for telehealth. Most of the people in the workforce were not prepared for telehealth.
Mm-hmm.
My question for you, the panel and people in the room, is what are we doing to prepare the future workforce for telehealth? Do you have any programs you're running so we can have a competent telehealth workforce in the future?
Oh my gosh, I think we need another 5 hours to talk to that question. The question essentially was, what are we doing to prepare the future workforce about telehealth? Any key nuggets anybody would like to talk about in the remaining 2 minutes that we have?
I think one of the things we have to do is to integrate it into our academic programs, whether it's, we're working with a technical college in our local community now, and for their CNA program, we're going to add a telehealth component to that. You need to add it into your physician medical school programs, into your nursing programs. I think that's a great way for any kind of healthcare provider to get a taste of what telehealth is and learn the basics about being a telepresenter and continuing with the confidentiality piece of it. But I think that's a huge component of it.
Yeah, this is something I'm extremely passionate about. So if anybody wants to talk later, let me know. But I was just going to say, I'm looking at 2 people that had a session earlier this week and another that's standing at the podium, so I can't wait. But there's some great work being done in telehealth education. And so I'd encourage, anyone to get involved, find those people and talk to them. How do they expand? How do they grow? So, and Gemma, go ahead.
Yeah, I want to remind everybody that it's not just clinician training. It's the workforce is changing all over. We created a new position called Patient Digital Ambassadors, where that's a combination of a medical assistant, an office staff person, and a tech person that does the technical rooming and helps prep the patient and train them and test them a day ahead. I think hospitals really need to consider, we have the equipment, we have the escort staff, we need tech runners. Nurses shouldn't be taking nursing time, setting up visits for a specialty consult. So I think the workforce is going to change. I think we can drive it. A lot of it, we're working with our technical community college to add it to, nursing curriculum, but also the non-clinical space really needs to grow and be able to support so that we don't have people at nursing cost and top of license setting up an iPad in a room. They have support so they can actually be doing nursing. So
that is a perfect note to end on. We are at the end of our time. I'd like to encourage everyone, though, to keep this conversation going. We have everyone's contact information, right? So you have the subject matter experts, the panelists' contact information. We have all of each other's. So let's keep talking. Thank you so much for coming. Please don't forget to fill out the evaluation information on Ineva Mobi. MATRC really does look forward to seeing that, and they use it. So thanks again, everyone. Have a great remainder of the day.